Hello, I'm Dr. Marisa Weiss. Thank you all for joining us to talk about the importance of diversity in clinical trials and what can be done to make studies more inclusive. Breastcancer.org is committed to helping eliminate health disparities in breast cancer care. And as we all know, access to clinical trials needs to be far more equitable. We believe everyone deserves the best care possible for their unique situation. That's why we're here today. Our new special report on increasing racial diversity in breast cancer clinical trials examines common barriers to clinical trial enrollment that disproportionately affect people of color. The report also offers resources and guidance for finding and participating in clinical trials. It's available to everyone at breastcancer.org/clinical trial diversity. We are partnering with amazing advocacy organizations to address disparities in breast cancer care. I look forward to updating the breastcancer.org community on our work in the coming months, especially our work with Ricky Fairley and Touch to better understand Black women's perceptions about clinical trials and provide tools and empowering information about clinical trial options. I'd like to thank our generous sponsors for making this event possible. Pfizer, Penn Medicine's Abramson Cancer Center and the Vassar Center, and Diachi Sanko, thank you so much for supporting breastcancer.org. Later in the program, we'll be talking with Sandy Omaro, head of clinical trial diversity at Pfizer. We're looking forward to hearing her perspective on improving clinical trial access. We are honored to be joined by brilliant leaders in advancing health equity. They each contributed to the new special report on increasing racial diversity in breast cancer clinical trials, and it wouldn't have been possible without their insights and expertise. Dr. Nadine Barrett is an associate professor in the Department of Family Medicine and Community Health at Duke University. She currently holds a joint senior leadership role as Director of Equity and Community and Stakeholder Strategy for the Duke Cancer Institute and the Duke Clinical Translational Science Institute, and directs the Center for Equity in Research. Dr. Barrett is a health disparities researcher and nationally recognized leader in training to address implicit bias and structural and systemic racism that limits diverse participation in medical research. Dr. Lola Fayanju is Chief of Breast Surgery at Penn Medicine. Helen O. Dickens, Presidential Associate Professor of Surgery in the Perlman School of Medicine, and Surgical Director of the Rena Rowan Breast Cancer Center at the Abramson Cancer Center. Dr. Fayanju's research lies at the intersection of redressing disparities and improving cancer care, particularly through patient-reported outcomes. After today's program, I encourage you to learn more from Dr. Fayanju in an excellent new breastcancer.org podcast episode available on our site. Dr. Karen Wingfield is Executive Director of the Meharry Vanderbilt Alliance, Ingram Professor of Cancer Research at Vanderbilt University Medical Center, and Professor of Medicine at Meharry Medical College. She is a radiation oncologist specializing in the treatment of hematologic and breast malignancies. Her work focuses on improving health outcomes for underserved populations through community-engaged research and community-based initiatives designed to improve access to healthcare, including clinical trials. Dr. Wingfield was recently appointed by President Biden to the National Cancer Advisory Board. And our moderator this evening is the CNN national correspondent, Athena Jones. Athena has covered several presidential elections and reported on the most important events and issues of our time. She is a graduate of Harvard University with a master's degree in journalism from Columbia University. Athena is also a two-time breast cancer survivor, and she will share her personal story of going through breast cancer twice under the age of 40. Thank you all for being here. This special report was also informed by the experiences of Black women who have participated in clinical trials. These women graciously share their expectations, fears, hopes, and positive impact by being involved in a study and the impact of the study on their lives. Several of these women also spoke with us for this video. Let's take a look.
I was given a 4% chance of survival.
I was 27 at the time.
I was totally frightened.
And I was not ready to die. I'm married and I have 4 adult sons and I have several grandchildren. I was diagnosed with triple negative breast cancer in 2015 through a routine mammogram.
I'm a single mother of one, of a son, a beautiful son, who is autistic and very alpha male. It's his way or no way. And I am the founder and CEO of Karen's Club. I'm a patient advocate. I was diagnosed with breast cancer originally in 2015.
I'm married. I've been married for 51 years. We have one daughter who lives in Los Angeles. I have been diagnosed with cancer twice. I definitely have beat the odds.
I work for a nonprofit here in Philadelphia. I was diagnosed September 2015 with hormonally receptive breast cancer in my left and my right breast. Before getting diagnosed with cancer, my impression of a clinical trial was not the best. In fact, I would think of negative things like the Tuskegee experiment.
I understand exactly what you're feeling when you think about fear. And because of all the historical atrocities that were put upon us, there are safety measures that are in place.
We need boots on the ground. We need to be able to answer the questions. We need to be able to tell the facts. I get the best of care in a clinical trial, the absolutely best of care.
I'm currently 6 years out of my diagnosis, and I am having conversations with my oncologist about possibly enrolling in a clinical trial. This clinical trial would test my bone marrow for disseminating tumor cells.
My original oncologist didn't think that a clinical trial was even on the horizon for me. And I was like, you know what? I think I want to try. I want to explore opportunities and make informed decisions. And after having genomic testing, the biomarker indicated that I was a very good candidate for immunotherapy. No chemotherapy, nothing else, just immunotherapy. And I was the first triple negative breast cancer patient in the nation to sign up for the trial.
I first heard about a clinical trial while watching a national television show. I Google everything and start making phone calls. I've been in a clinical trial for 3 years now at University of Penn. The goal of that trial was to look for dormant cancer cells.
I was introduced to the idea of the trial by my oncologist at that time. One of the things they explained to me in the blind study was you may not get the immunotherapy, but you will get a medication that will help you fight the cancer. I still have cancer sitting in my sternum and a couple of spots on my lung, but they're not getting any larger. They have gotten smaller.
When I think about contributing to a clinical trial, I also think about the young Black women who will be diagnosed under the age of 40 with breast cancer, and how my data will be able to help scientists and oncologists give them treatment that's better than the treatment that I'm currently getting.
As Blacks, we need to help research. We need to get in research. We need to partner with science, and we definitely need to learn and pass that information back to our community.
I think about it as a science-based tool in the arsenal of fighting cancer.
Clinical trial gave me hope.
Opportunity, innovation, and hope.
I am a cancer survivor and thriver thanks to clinical trials.
Wow, that was really very inspiring. I want to thank the amazing women who participated in that study and who graciously shared their story. Eva, Sharon, Karen, Janae, thank you for sharing your stories and experiences with us and for inspiring all of us to advocate for our health, just like you did. Now it's my pleasure to welcome Athena Jones. We are honored to have her here today to share her story and moderate the panel discussion later in the program. Athena, you were diagnosed with breast cancer twice before age 40, which is under the recommended age for routine mammograms. How was the breast cancer found each time, and what was your reaction?
Well, hi, thank you for having me be a part of this panel discussion. I'm very interested in this topic, of course. I was stunned. I was first diagnosed when I was 36 years old. I come from a very big family. I have dozens of aunts and uncles and great aunts and uncles and dozens more cousins, but I wasn't aware of breast cancer running in my family. I didn't know anyone else personally who had it. And it wasn't at all on my radar. It was caught at 36 because I had gone into my gynecologist who said that this happened to be a woman a doctor who believed that she should offer a baseline mammogram to her patients who were 35 or 36. I somehow missed it at 35, but at 36, I went in and she presented the idea to me and I said, sure, why not? And so that's how my initial cancer was found. That was extensive DCIS just on the left side. And it showed up, of course, as kind of scratches on an x-ray, but it was stunning. I had a lot of tests after that, biopsy, and still was surprised when I was told that I actually did have extensive DCIS. That was 2012. 3 years later, so I went through treatment, double mastectomy, but no real follow-up. I consulted a radiation oncologist and we determined that I didn't need to do a radiation. But 3 years later, the cancer came back. This time, same side. I felt it as sort of several frozen peas, like think of a bag of frozen peas. I could feel it myself. And I went back in and luckily I was under close surveillance. And this time it was invasive. So this time I had to both have surgery and chemo, 4.5 months of chemo, and then radiation as well. So both times I was stunned though, because it was not something that was on my radar at all.
Wow, and it's just to hear you speak tonight about it. I mean, it just brings it back, doesn't it, when you share your story? And you've had a lot of publicity as a reporter for CNN. What was it like being on TV while going through chemo and radiation?
Well, I'll say something sort of broad and something more narrow. The broad thing is that I wore a braided wig. At the time, I was wearing braids. I found a company that sold braided wigs, and I used that. And certainly a lot of Black people noticed, but many, many people didn't realize that I was going through anything. And so in that sense, because I kept it private, I only told a few of my managers and a few close friends and family. Even though I consider myself certainly an advocate and believe in speaking up about this and working on projects associated with it, at the time, I didn't want to be public. This is the larger or the more narrow reason. I didn't want to be public about it back in 2012 because my mother at the time was very, very sick and bedridden. And I didn't tell her right away because my concern was that she would want to come to my surgery and she would need her own nurse. And for all those kinds of reasons, I didn't want to be more public about it because there's no way that she would not have found out. So in general, these were things I kept private. And in that sense, I just kept going. For me, I was covering the White House the second time, the time I went through chemotherapy. And I just kept going. And it was really good to be able to have that kind of steady schedule. They worked with me, put me on a morning shift, a permanent morning shift where I had to be at the White House at 6 a.m. or 7 a.m. But I was finished every day by 1. Every 3 weeks I had chemo. I was still able to go on almost all of the foreign trips that President Obama went on. So for me, continuing to work was, I guess, kind of a welcome distraction for someone who wants to be part of covering the news. But in terms of having to deal with other people, comforting them or their well wishes, only my closest friends really knew, and they all, of course, rushed out and got mammograms.
Wow, I mean, what an extraordinary story. And the reality is it takes a lot of energy to share your story and to comfort those people who care about you that are upset by it. And you needed all your focus and strength and attention on your treatment and then doing your job, right? But we're so grateful that you're sharing your story now, because when people see you this many years later, it's a source of inspiration and encouragement. When you were diagnosed in your 30s, were there any unique challenges that you faced by getting breast cancer in your 30s? What were they?
Well, certainly. I want to mention that I began sharing this right after I was kind of done with treatment. So back in 2017, I wrote an article for Self about it, encouraging people to consider getting mammograms, at least one mammogram younger than 40. But I'd say, it's never a good time to be diagnosed with cancer. No one ever wants to get that news. And I don't think anyone would say, well, okay, if I'm going to get that news, make it be at, X date of my life, unless it's 85 years old or 95 years old. No one wants to get cancer, but getting it in your 30s, especially back to back, it seemed to me, this is a time when you're trying to really establish yourself in your career. You're trying to go only up in one direction, but that's not how life goes. And for me, it was disruptive. That's the bottom line. The first time I was diagnosed, I was dating someone who took good care of me, and I had a real strong support system through him and his family and my family and friends, of course. The second time I wasn't dating anyone, but I still had a support system. And there were just kind of ways that I felt like, my life plans were disrupted. Certainly on the professional side, I was covering the Republicans running for president back in 2015, 2016. And it was in 2016 that I had to leave the campaign and to have the surgery and then have the reconstruction and all of the later, the radiation and chemotherapy, all of the later treatment. So that was the main thing for me. It takes a while to get back on track or to feel like you're back on track when it comes in that middle time.
Yeah, it's such a journey. And, hats off to your gynecologist who, really suggested twice, to get that mammogram, even starting at that age. It could have been what saved your life
Absolutely.
And thank you to her and again to you for sharing your story. In a little bit, you'll be moderating the discussion on diversity in clinical trials, which is one part of the larger issue of achieving health equity. Why do you think it's so important that we have these conversations?
I think it's important because if you aren't aware of a problem, then you're not going to be trying to fix it. If you can't see it, it's not on your radar. It's not something you're going to work hard to find the solution for. And so I think that any kind of raising awareness, certainly when it comes to this, what we know is a multifactorial or multifaceted issue, which is why are Black women so much more likely to die of breast cancer in this country than white women, and more likely to die than any other race. And there are many parts to this problem and many parts to the solution. And this is certainly one of them. And I know we'll talk about this later, but when you look at things like triple negative breast cancer, which Black women are way more likely to get, there needs to be Black women part of research looking into developing therapies for that very aggressive form of cancer. So just like with the screening, mammogram screening, I happened to be lucky enough to have that doctor who believed in doing an early baseline mammogram. And thank God I did, since it wasn't even something I was thinking about. And so we have to make sure that people begin to think about these things. This is of course geared towards patients and doctors, current patients and doctors, but more broadly, people should be thinking about these issues and being able to look at it in these sort of multifaceted way that we're doing now.
Absolutely. Well, thank you, Athena, for sharing your story and for moderating our panel this evening. I would like to now go ahead and introduce Dr. Nadine Barrett. We are so fortunate to have Dr. Barrett as an advisor on the work Breastcancer.org is doing to address health disparities.
Excellent. Thank you so much. And now, what an inspiration, both with the video and certainly Athena, just hearing your story, the story of so many who are actually even on this call and this session tonight, really moving. And you all are our heroes in so many ways in highlighting the importance of addressing these disparities, most certainly in the lack of diversity in clinical research and trials. So thank you all for sharing your inspirational stories of survivorship and leadership and commitment and self-advocacy toward that change. So thank you. And thank you for having me here tonight. I'm going to share a little bit about some of this work. And so I think one of the things I'd like to really start with is this important concept, right? And it really is important when we think about diversity in clinical trials participation. It truly benefits everyone. And so no matter how much we may think about clinical research and clinical trials being very specific to one particular group or another, the reality is that we need diversity. And we know that clinical trials can directly impact an individual enrolled in a clinical trial. And we'll be able to talk about that in a bit. So we'll talk shortly a little bit more about why that's important and how it can impact individuals as well as a broader society. But let's think a little bit more then about the big picture, the data. The lessons learned from a clinical trial are stronger if they are based on observations and outcomes from a variety of people who reflect the diversity of our patient population. When a new drug is tested for any kind of illness, breast cancer, or even a less serious condition, we need to see how it works for different genetic, geographic, socioeconomic, and racial groups. Depending on the study, there could be other important factors like having different genders, ages, body types, or a specific health history. And when we don't have a diverse group of participants in a study, the evidence about how a treatment works is limited. We can't know for sure how safe and effective it is for people who aren't represented. So again, this highlights the importance of this. These are the circumstances for many clinical trials today, unfortunately. Researchers could learn so much more about how to treat cancer if their research had better representation, better diversity. So now let's go back to individuals in a clinical trial. So we're going to talk a little bit about that, and then we'll talk again more broadly. But right now, let's talk about individuals at a trial. And let's talk specifically about trials for new therapies to treat cancer. Being in a clinical trial could extend and even save someone's life. It can give someone access to the new treatments and to attentive care. That kind of opportunity to live longer, to have a better quality of life, should be available to every race and ethnic group. But right now, most people with cancer in clinical trials are white. The statistics about clinical trial participation show us how much work we have to do so everyone can be helped by these new treatments. But let's be clear, this is not a new problem. People of color have always been underrepresented in clinical trials, but there is a new focus in the research community on improving inclusion, some of it driven by COVID-19. And there are now more resources than ever before for patients to find and participate in clinical trials. So we need to be talking about this with our doctors, and our network of friends, and with our families. And that's a critical part of us helping to move that needle and creating equity in this space. For Black women, breast cancer poses a unique threat, and doctors and scientists are trying to figure out why. In the US, Black women and white women get breast cancer at the same rate, yet Black women are 40% more likely to die of breast cancer. That is startling and an unacceptable statistic. Disparities in clinical trial participation among Black women could be one of the reasons they have worse breast cancer outcomes than white women in the United States. Including more people of color in clinical trials benefits everyone because diversity of participants strengthens the evidence we can get from research. But will also give more people of color access to cutting edge new cancer treatments that are discovered almost on a daily basis, and that can sometimes improve outcomes and ultimately save lives. So we may ask the question then, why are people of color underrepresented in clinical trials? What are the barriers? What are the factors that impact that? Well, first, we'll go through a few. First, not finding out about clinical trials or about clinical trials that may match their situation. If you don't know about them, you're not able to find them. And when you do, you're not able to know where to find ones that match your condition, then most certainly that can actually have a huge impact. Second, lack of trust in institutions and even in research and the research teams who are running the clinical trials. I often like to refer to this also as not so much that people lack the institutions, but there's been a lack of trustworthiness in medical institutions and in research that many of us can relate to and know about from the past, and more currently, that also impacts that trust, right? It erodes trust. The expense of participating That also is a barrier, like paying for parking, gas, hotels, and challenges with insurance coverage for routine care. There's also overly strict eligibility criteria that can become a barrier to people being able to participate in clinical trials. We know that needing to travel to a hospital where the clinical trial is based most certainly plays a huge part, most certainly if you can't file trials that are close to you. And possibly needing to miss work or find childcare. Another challenge that some people can't afford to miss work, and they certainly have the challenges of having to find someone to take care of their children. All of these are barriers that most certainly play a part in increasing diversity in clinical trials. And we're going to be discussing these barriers to participation with our awesome panel later on in this program. But one thing is for certain, we need to understand these issues to overcome them. And that leads us to a critical part in asking the key question: what can be done to improve access? We're going to get into this in more discussion with our panel in just a bit. But for starters, here are some things I'm looking forward to discussing with Dr. Fayanju and Dr. Winfield. First, how can we make clinical trials more convenient, more accessible to Black women and people in our underrepresented race and ethnic groups? Doing more research to understand the barriers to clinical trial participation we talked about earlier. How can we do more research, and how do we ensure we understand that? Also, expanding eligibility criteria. What would that look like, and what suggestions and recommendations do our panelists have for that? Covering the costs, as I mentioned before, when we think about gas, treatment, care, all of those things play a huge part. And for example, one of the things that has been a huge change is starting in this January 2022, state Medicaid programs will cover routine care costs for all clinical trial participants who have cancer or other life-threatening conditions. This is a breakthrough opportunity because in the past, people with Medicaid could not participate in a clinical trial simply because they had Medicaid. So this is a huge policy change that will open the doors and increase access. And here's something that you can do. Advocate for yourself. We heard that from the videos. We've heard that from Athena. How do we advocate for ourselves? And how do we ask our doctors if there's a trial that could be a good match for you? There's a lot of work doctors need to do. There's also focusing on training that our providers need. So for example, I have a training that I developed called Just Ask training. As we know, one of the number one reasons why most people are not participating in clinical trials is because they're not asked, they're not informed, or they don't know about it. And some of the things that we also know is that some may make assumptions about Black women, thinking that they may not participate because they may be challenging, they may not understand what's expected of them, they may have barriers, but who knows, that they make assumptions about those barriers, but those barriers might not even exist. So we do training to help our research teams to really start thinking critically about what are the assumptions and perceptions that they have that are actually creating barriers for Black women to participate in cancer trials. We have a lot of work to do. And without question, when we think about clinical trials, we can't cover everything here tonight because there's a lot to discuss. However, let's talk about some of those facts that we can share with others to counter some of the misconceptions about clinical trials, many that I've had and some that others have shared also through the video. So there are some facts that may help someone decide to enroll in a clinical trial. First, or one, clinical trials are not just an option when standard treatments are ineffective. In fact, there are clinical trials for all stages and all types of breast cancer. Secondly, placebos, sugar pills, often called, are rarely used alone in cancer clinical trials. They may be used in addition to standard of care. A third misconception that we have to address is participants have the right to leave a trial at any time for any reason. Remember, by participating in a clinical trial, you are a volunteer. And also, the doctors you'll be seeing during that clinical trial will be carefully monitoring your safety, and they will inform you if and when it's a good idea to stop the trial and discuss a different treatment option with your care team. Another key point is new medicines are tested for many years in the lab and animals before they are ever studied on people. And those are just a few of the misconceptions that exist, but most certainly there's others for us to consider as well. So the next question then is, if you want to explore the idea of a clinical trial, are there some first step questions that you should ask your doctor? The first step is that you should ask your doctor. If your doctor isn't knowledgeable about clinical trials or isn't willing to look at options for you, you may want to get a second opinion. You might be referred to another doctor at a different medical center who can meet with you in person or in a telehealth appointment. I want to assure you that there are organizations that's also dedicated to helping you search for a clinical trial match that's right for you. Organizations like breastcancer.org, the Lazarus Cancer Foundation, and Omaro Center for Women with Advanced Cancer. These are all great resources for us to explore and for you to look at when you're thinking about engaging in a clinical trial and participating, or at least making an informed decision about whether it's right for you. So whether meeting with a doctor or searching online for yourself, what do you ask and look for to gain the knowledge and confidence you need to participate and to proceed to participate in a clinical trial? Questions like, has this treatment been tested before? Or what are the side effects? What are the costs? If the treatment works, can I continue to get it after the trial is done? That is just the beginning of the wealth of questions that many people have, many of you may have, when it relates to thinking about participating in a clinical trial. And you can actually get more questions and read about them on breastcancer.org/clinical trials. That being said, for more information about diversity in clinical trials, as you've seen here in these few minutes, the need for more representation is critical. The opportunity to advance health equity, to close the gap in the disparities that I've talked about, really is about, and a key part is increasing diversity in clinical trials. And you can read the new breastcancer.org special report at breastcancer.org clinical trial diversity. It's an incredible special report, incredibly comprehensive, and this just gave you a taste of all the information that you can get to really be able to take the first steps in advocating for yourself and being able to participate in a clinical trial. And I'd like to welcome back Athena and ask my colleagues and friends, Dr. Fayandru and Dr. Wingfield, to join me. Excellent, thank you. And I'll pass it to you, Athena.
Wonderful, thank you so much, Dr. Barrett, for that wonderful presentation, really laying out many of the barriers standing in the way of more diverse participation in these clinical trials. This conversation will give us an opportunity to dive more deeply into several of the points you made. So let's start with understanding one of the major barriers you laid out, barriers to clinical trials enrolling more Black women, and that is that doctors aren't discussing it with their patients. Why aren't more doctors talking with their Black patients about clinical trials?
Thrilled to be here, and great to see my good friend, Dr. Barrett, on this call as well. So one thing I want to emphasize is that, frankly, doctors aren't good about talking to trials to anyone. The truth of the matter is, and again, it's not because of any malintent. Often it's just that as part of a busy clinical practice and a busy clinical day, coordinating just routine standard of care can often be quite challenging and, granted, distracting from the idea of also connecting patients to research. And then what happens is that often it's the whole squeaky wheel phenomenon. You know, those who come to you and say, I'm interested in research, you're more likely to go out of your way to try and connect that person with research. Nonetheless, it is obviously very clear that physicians are less likely to discuss research opportunities with their patients if they are people of color, if they are perceived as being potentially difficult enrollees, people who there is concern for adherence, quote unquote, or for long-term participation, or for whom comorbidities might contribute to lack of efficacy of the intervention in question, or a need to be disenrolled from the trial. So all of those things, I think, contribute to the types of biases that systematically exclude Black patients from being approached. But I will also say that there's a larger problem of trying to approach all kinds of patients for clinical trials. With regards to other types of people of color, there's also the language barrier. Many clinical trials are not really focused on making sure their consents are translated into different languages, which represents another barrier that people, frankly, don't bother offering their trials to people who may speak Spanish or other languages because they haven't gone through the work of getting a consent into that language. Now, I will also say that one of the things that we can really think about doing with regards to making sure clinical trials are offered equitably is to decouple the encounter where a provider has to offer it from a more kind of broad brush general approach to clinical trials, where there is a generalized screening of clinics prior to the clinic for any eligibility of trials, such that everyone has an opportunity and there isn't this kind of selection bias associated with who you think would be a good candidate for a trial. I would argue that that actually will lead to better science as well, because it means that we are truly trying to get a diverse and randomized sampling of the population for these trials.
Thank you, Dr. Fayonju. And Dr. Wingfield, would you like to weigh in on this and on this idea of doctors making assumptions about whether their patients would be a good candidate or be able to carry out the entire clinical trial, or anything else about this issue?
Yeah, absolutely. So first of all, I want to thank the organization for kind of inviting me, and thank you very much for sharing your story, Athena. It was very powerful, and awareness is key. And knowing that breast cancer can impact people of all ages is really vital. So thank you for sharing that story. I do want to echo what my colleague has mentioned, in that we're not doing a great job across the board at offering clinical trials. But I must say, you are sitting right here amongst one of the greats when it comes to implicit bias training. Dr. Barrett knows I throw her under the bus all the time about, oh, she's got a program on implicit bias. And that's one of the things that is real. And we all come with our own assumptions, right? I mean, we do. We make assumptions about people that we might be seeing in the grocery store, about who they are and what their capacity is, and what kind of car they're driving. We make assumptions all the time. And so it's no different for clinicians and providers. And so we need to be aware of those, though. And that's part of the challenge, is there really hasn't been enough emphasis on people understanding what those biases are. But then we already heard, this conversation around how do you actually create specialized programs that kind of bypass the bias, right? Is there a way to take the selection of clinical trials and who might be appropriate for clinical trials out of the hands of the provider at the counter, where they're trying to have these complex conversations about treatment, et cetera? So I do think that there is that issue of bias, but we've got to create within systems things that can help to bypass the biases that are inherent within the system. But we also just need to learn how to ask and make it clear why we're asking for people to consider participating in research studies that are so vitally important to taking cancer care to the next level.
Certainly. Thank you, Dr. Wingfield. And Dr. Barrett, you obviously gave the presentation on this, but I'm sure you have more to add on this idea that both Dr. Fayonju and Dr. Wingfield mentioned, which is this idea of selection bias and kind of taking the decision out of the hands of that immediate healthcare provider. Can you expand on that to make sure everyone understands what that means and what that might look like? Does it mean having sort of the standard of care be that every single patient is evaluated to see if they could fit into the criteria for certain clinical trials that are already going on, or what?
Yeah, there's all kinds of multi-pronged ways in which we could actually, I call them different touch points, if you will, across the process that we could actually look at, investigate to really determine what are some of the best ways that we can bypass, as was said by my colleague, the biases that exist. And it's a combination, right? Because people hear the words "you've got cancer" in all kinds of settings, in rural hospitals, academic hospitals that are, hospitals that are connected to a university, for example, that does research, the local community clinic. I mean, there's so many places in which people hear the words "you've had cancer," and then so there's also an opportunity. And now I'm actually taking some of Dr. Wingfield's area, is where there's great networks in which we would engage different types of health settings, so that people can hear the word, when they hear the words "you've got cancer" or "you have breast cancer," they can also say, and there are some clinical trials that's available to you, even if you are in the most remote areas of the country or in other countries for that matter. And so I think that there's an opportunity for us to really start thinking about what that process or that system looks like, and based on where people live. How do we get clinical trials in a space where people can actually get access to it, regardless of where they live, one, and how do we work with our systems and our providers to be able to know what that ask should look like? So what we've heard a lot from our community and patients who were interested in participating in clinical trial but never heard about it was that, one, they were never told there was such a thing as a clinical trial. We also hear a lot of people talk about the fact that when they do want to participate or there's an option that they can't get access to it, as I mentioned before. So how do we get them and get it? To have the relationships and the interaction between types of systems to ensure that happens. And last but not least is that the reality is that the provider actually has quite a bit of influence on someone participating in a clinical trial or not. That's the first person that most people say when they participate in a trial is because they heard it from their provider. So we still have to think about what kind of training the providers need to be able to have that ask. And then maybe it is a quicker transition from that provider to someone else because of the points that were highlighted by Dr. Fayandru. But I think that one of the key things is for us to consistently work on the system, the experiences, the process, but also the individual, because that encounter is important. And people start to trust their oncologist the minute they hear they've got cancer. They're like, what do I do? Because people are lost, they're hurting, they're confused. It's a complex time. And so how do we make sure that everyone gets to hear it and then they get access to the appropriate staff person that can be able to manage that conversation in a respectful, supportive, and a way that they really and truly hear and listen to that patient.
Thank you, Dr. Barrett. It would be wonderful to imagine that everyone will get a full picture of the possibilities when it comes to treatment very early on as possible, because it helps with hearing that terrible news. And Dr. Barrett, you mentioned trust, and that is another major barrier to this whole issue, to making sure that more Black women get involved in clinical trials. There is a lack of trust among many in the Black community in the healthcare system. It's a critical issue. You talked about some of the history behind that, experiments like the Tuskegee experiment. What are some of the other factors that contribute to this mistrust? Implicit bias is one of them, but what are the other factors that contribute to this, and how do you get around that? How do you what's the answer there? And I'm not sure if you want to go first, Dr. Barrett, or who else?
I'm happy to, and I'll make it brief so that my colleagues can certainly share their perspectives, because I know they're really incredible. So one of the things that I think is really important as well when it comes down to trust is that we're really starting to change that conversation. And instead of saying the community or the patient lacks trust, we're starting to say, how do health systems and researchers become trustworthy? And so that way the onus starts first and foremost removed from the patient and the community, and starts recognizing that the lack of trust actually comes from historical and current negative experiences. As a sociologist, I can't help but also add that the trust is not just about the health system. It's actually the lack of trust across health systems in general, any system in general. So whether you're talking about criminal justice, education system, if you're talking about the health system, all of that is part of it, because these systems were never designed for Black people to really be successful and to thrive historically. And so if we really want to think about that in terms of health outcomes, that plays a key part in it. Can we change those systems? People are working toward that. But in the meantime, how can we start in our own backyards as health system leaders, partners, researchers, and physicians and clinicians? How can we start to make a difference in that space? And I think it's a both and. It's arming our docs and our oncologists who are having that conversation with the patient, but also just with what Breastcancer.org is doing, really helping patients to be able to advocate for themselves in that position. My goal is ultimately to know that when someone hears the words, you've got cancer, and a clinical trial may be an option for you, they can say, yes, I've been hearing about clinical trials in my community for the past 5-10 years now. That's my ultimate dream. And so again, I think that it's a multi-pronged approach which should happen on both sides.
So much of this involves making sure that all of this is being communicated to the broader community beyond a session like this, but kind of that it becomes part of the conversation. What do you have to say about this issue of mistrust, Dr. Wingfield?
Yeah, you know, I think it's fascinating. We're learning a lot from COVID, right? And I think this concept of clinical trials has become more and more apparent, right, as people have heard about it. And we're hearing, you know, a lot of the things that Dr. Barrett had mentioned in terms of the mistrust of systems. And that's where the structural racism has really had a huge part to play. And so in order to kind of combat some of the trust issues, it's really important to make sure that you have people who are from and of the communities that you're trying to serve as part of the solution. Number one, you need them at the table. You need to talk to the communities that you're trying to serve and make sure they're part of building the solution and not just like saying, oh, well, here's the solution we came up with. What do you think? We're talking about true community-based participatory, not only research, but really engagement. How do you engage communities? And that's that bidirectional communication. In the short term, there are some real good things that can be done immediately that can actually provide some support. And that's around workforce diversity. And look, I'm a radiation oncologist. You know, you have and it takes us 5 years, right, to actually go from medical student to a full-blown and full-grown radiation oncologist. Medical oncology can take 3 years or more. And, you know, you talk to Dr. Fianju, and, you know, she's a surgeon, and it takes her even longer, right? So I think we're not just talking about the physician workforce. And let me give you an example. When I was the associate director of the Cancer Center at Wake Forest in North Carolina, one of the things that we were able to do is put together a population health navigation program. And that was actually starting in the community, where we started having conversations with community members before they were diagnosed. So to Dr. Barrett's point, starting in the community, talking about, you know, not only just cancer awareness, you know, health promotion, but also talking about clinical trials in the community. When people walk through the doors, it's no longer foreign, but then also supporting patients during their journey. And I was really intentional in making sure that the providers in that navigation program were from and of the communities we're trying to serve. We had deficits when it came to Hispanic population, African-American population, and rural population. We found people who were from and of those communities to help support patients as they walk through the door in the cancer center. So we can really think strategically. Who's at the front desk? What do people see when they walk in? Is it welcoming, right? I mean, you know, if everything you see around you says this place is not for you, people are going to backpedal. And especially when they're coming to large academic centers, as Dr. Barrett was saying. Certainly clinical trials can happen in smaller places, but that's typically not the case. Typically research of this sort, particularly when we're looking at metastatic breast cancer patients in particular, who oftentimes have gone through standard course of therapy and might need to get immunomodulators or other sorts of therapy, that's going to be done at a big academic center. It could be scary for folks. So you have to put workforce in place that looks like and is from the community that you're trying to serve.
Yes, it's so important to be communicating with the community, with the broader community, even before they get to the point where they might be someone who could benefit from a clinical trial. And that involves talking to people in a language they can understand in a way that isn't so intimidating and isn't talking down to them. What do you want to add to this discussion, Dr. Fianju, in terms of mistrust itself or ways you've seen it effectively be overcome?
So I think language matters a lot, and also recognizing that you're not going to use the same language with all people from a particular racial ethnic group because there's heterogeneity in all groups. And so in a study that we conducted that was published a couple of years ago, what we actually found is that amongst African Americans, people who are of higher income were actually less likely to participate in a clinical trial than those who are lower income. And that is something that is actually a signal that's now being seen in repeated studies showing that, you know, in individuals from communities who have reason to distrust our healthcare system, those who have more means and more opportunities to choose where they access care and how they access it are more likely to exercise that choice and remove themselves from what they perceive to be potentially speculative opportunities such as clinical trials. So the word randomization is a very loaded one that is regularly used with describing clinical trials. And the reason for randomization, or the idea that you are assigned to one or the other arm in a trial, is because we're trying to achieve balanced groups that look very similar with regards to age, sex, race, disease subtype. But the only difference in those groups, therefore, would be the intervention that's being tested. And so that's the purpose of randomization. But most people, what they hear is the word random, and they run with it. And they think, I am not subjecting myself. I, who have overcome generational disadvantage to have the opportunity to make my own choice, I'm not going to subject myself to a random process. And so recognizing that we need to honor the journey people have made and the position they now may have acquired that makes them more loath to participate in clinical trials is important. I think that when people talk about appealing to the Black community, we need to, again, acknowledge the heterogeneity of the Black community, acknowledge the heterogeneity of the Latino community, acknowledge the heterogeneity of the Asian community. We can't just assume the same message is going to work for everybody. One great example I will tell is of a friend of mine who's a plastic surgeon. He's a white man, a very good scientist and surgeon. And he explained how he was describing to a patient that he was going to do a free flap, which is a type of reconstruction where some of the tissue from the abdomen is moved to the chest to create a new breast mount. And in the past, we used to do what are called pedicle flaps, where the same blood vessels that were in the abdomen were connected to the ones in the chest to feed the breast. But now we often detach those and actually make a new connection using microscopes. And he was discussing this woman the idea of a free flap. And then she had surgery and had a complication. And she said, doc, I just have a question. I have insurance, I have money. Why did you think I needed a free flap? So she had interpreted the word free to imply charity, to imply that he did not think she could afford the top of the line care. And he describes how everything just went downhill from there. And I thought, gosh, the things we take for granted in the medical world in terms of assuming even what many of our, very educated but non-medical clientele will think, and how that erosion of trust early on can really be very hard to overcome. So language is important. Dr. Barrett's program of educating people across the continuum of care, such that when you interact with people, your patients, and talk to them about clinical trials, you're using thoughtfully conveyed language that doesn't, basically seed distrust in a system that, frankly, is not always trustworthy.
Wonderful. Thank you, Dr. Fayonji. Certainly communicating in the right way with the right people at the right time or consistently is really important here. I want to, for a moment, take a slight detour and talk about more conceptually what we mean when we talk about the need for diversity in clinical trials. This is obviously about Black women and minorities not being well represented in these trials, but what exactly do we want? What in an ideal situation, what kind of groups would be represented? You hear a lot of talk, especially in recent days, about race as a social construct, a lot more talk about it, I should say, that this is something that society has come up with, the idea of Blacks and whites and separating people by race. It's not nearly as important physiologically as genetics. So what do we mean when we talk about race versus genetics? What other aspects of diversity are important in clinical trials? Are we talking about geography, socioeconomic? Talk about that. Maybe Dr. Winkfield can start.
Yeah. This is, you see, I was starting to itch. I must say, so this is an area that is really meaningful to me. Look, I'm a biochemist, right? So my PhD is in biochemistry, even though I'm a practicing clinician. I did do research, and it was very important to me to understand why it was that Black women were dying of breast cancer at a much, at more often, younger age, et cetera. So while race is a social construct, it has been used for a very, very long time as a surrogate for racism, right? And when you have those isms, when you have those structural barriers, that does impact how your genome is expressed, how your genes are expressed. So while if you look at different people across different types of population, whether it be Hispanic or white, there may not be as much variance in terms of their genetic material as you'd think, but the way that that gene gets expressed may be different. And we see this, it's called epigenetics. Okay, it's a big term that just means what happens to the DNA and how it gets expressed. And let me tell you, we see this a lot with cancer, with patients who actually smoke, right? So smokers, if a woman is smoking and she gets pregnant, we've actually seen in that child will have an increased risk for obesity. And in fact, even if that child does not smoke herself, if she then goes on to have a child, that second generation also is at risk for obesity. Okay, that's an epigenetic phenomenon that is well known. Okay, so you can imagine how much trauma is experienced from microaggressions, macroaggressions, from all of the experiences, from all of the structural racism that's been, levied against Black and sometimes brown. I mean, I'm telling you, our American Indian, our Native population, indigenous populations are also suffering from a lot of those same things. That trauma is represented in how those genes are expressed. So this is why it's really important to make sure we have diversity of race and ethnicity, despite the fact that it's a social construct, but also in terms of gender, right? There is male breast cancer. We need to make sure that those treatments work the same as in men. We need to make sure that if people have different comorbid conditions, if they have diabetes and high blood pressure, which are more prominent in African-American communities, again, because of the structural racism, we need to make sure that the medicines that we are kind of using are going to work the same in all populations, not only in terms of efficacy, meaning how well they work and how well they destroy cancer, but also are the side effects the same? And so what we want is for people to survive cancer, but to survive it well. And we want to make sure everybody has that opportunity. And this is why that diversity is really important.
Wonderful. And Dr. Barrett, will you weigh in also on this idea of what diversity means in a clinical trial? I imagine you'll agree a lot with Dr. Wingfield.
Yeah, I agree completely with Dr. Wingfield on that. And she touched into everything from the systems of structure to genetics and ancestry as well. And so I really wouldn't add much more to that, except for more hone in on just how important it is for us to understand the impact of trauma, the impact of race and racism, and how that plays out multi-generational, just as was said, that ultimately impacts our genetics. And so as just anything else does, that, we talk about public health crisis, smoking, racism is a public health crisis, and it has a significant impact on people of color, particularly Black people in this case. And so it's critical for us to understand that and for us to really recognize the differences between the social construction and the biological. Sometimes in research, we tend to kind of hone in on this biological difference between Blacks and whites. And that biological difference is very much so significantly related to racism, historical racism and structural racism over the centuries. And so I think that that's just always important for us to note that difference that we don't often do. But yes, I agree with everything Dr. Winkle said. She's totally right.
This conversation about sort of the impact of structural racism and generations of inherited trauma and the whole field of epigenetics, I think is really interesting. But Dr. Fayandru, I'm hoping kind of in this same general topic, but narrowing down on this idea that, if you go to West Africa, where many Black people in America can trace their heritage to, Nigeria, Ghana. These are places where triple negative breast cancer is a lot more common, or is a lot more prominent percentage-wise. I don't know the exact percentage, but a lot more than it is here, 10 to 20% here. It's a lot more common there. It seems to suggest there is a real genetic link between with this cancer and the Black population here. Is that another reason that it's important to have diversity, specifically in breast cancer research?
Well, absolutely. So my family is originally from Nigeria, and if you talk to almost any Nigerian person, you will know a story of some woman who died young from breast cancer. So triple negative breast cancer represents about 10-15% of breast cancers in the United States, but is twice as common among Black women as opposed to white women in the United States. And in West Africa, it is estimated to make up as much as 40% of breast cancers in West Africa. And given that many women there don't have access to screening, and therefore are much more likely to be diagnosed at a very late stage, there may be stigmas associated with even seeking cancer treatment or acknowledging the diagnosis. The rates of mortality, as you can imagine, are deplorable and disheartening. So when we think about clinical trials, I would love to get to a border-free world where we were really thinking about how to make sure we are testing interventions across all groups in all countries. Because what we've also learned is not only would developing targets for triple negative therapy treatment, as we develop for HER2 positive disease, would improve outcomes amongst the many Black women and women of African ancestry around the world who disproportionately suffer from it, it would probably also elucidate the pathophysiology of that disease. So an interesting fact is that a commonly mutated tumor suppressor in breast cancer is the P53. And what we found is that it's not only more commonly mutated triple negative breast cancer and more commonly mutated in Black women, it is also strongly more associated with socioeconomic deprivation. The same type of pattern that's seen not only in the south side of Chicago, but also in Dundee, Scotland, amongst poor individuals there in a very white homogeneous community. So that's all to say is that everything that Dr. Barrett and Dr. Wingfield have said about the epigenetics of stress, the epigenetics of poverty, which is another public health, I would say, scourge, and one that frankly is being exacerbated by the COVID-19 pandemic, and by global shifts away from social networks and systems that support poverty, support people who are in poverty. And it's not just happening in the United States. Again, I think in terms of a border-free world, we're seeing increases in child poverty even in nations that historically have had strong social fabrics, such as the UK, such as Canada, and that are also not coincidentally, I think, becoming more diverse. You know, it's interesting how suddenly, when we used to think it was really a priority to care for the whole population, when that population starts to look a little bit different from how it looked 100 years ago, suddenly we start pulling that social net back. So I'll put that out there too. So I think that there's a lot of work to be done to make sure, again, that we approach clinical research in a way that really thinks about the global community of breast cancer patients. It is the most common it's increasingly the most common cancer around the world. It used to be cervical cancer was more common in the global south, but that really is breast cancer rising to beat that. And I think it's to our peril. I think we will understand the disease less well. It means we're practicing less good medicine because a larger portion of our country and of our planet cannot benefit from the trials that are being undertaken. And I think one of the things we really need to do is think about how to partner with scientists and clinicians and community health workers across the globe, in the Caribbean, in West Africa, to think about how we can really get clinical trials to women in a way that is not exploitative, but really elucidates, again, the pathophysiology of a disease that definitely has some genetic ties to West Africa, but is not fully explained by the high levels of African ancestry amongst people, Black people in the United States.
Thank you. This is really fascinating. I mean, it sparks so many other questions, but we will stick to the ones we have here right now, which is the next one being, what do you all think will motivate the research community? You guys are obviously committed to this, but this kind of coordination, forget global, but even just here in America, in states and cities, what will motivate the research community to do a better job of enrolling people of color in clinical trials? And how can they be held accountable for doing so? That's a two-part question. Maybe Dr. Barrett, you could take a stab at both or either one of those parts.
Right. Well, given the audience that we're speaking with, I would say one of the key things to all the part of this community tonight is really patient advocacy. I think one of the things that the more our patients start to bring it to the providers and ask them for that and say, look, this is a key part. I want to know more so I can make a decision on what is best for me. And if I don't get all the information, including what clinical trials may be available to me, or at least letting me have that conversation, I think that that's a critical part to that. I also think, though, that there's this other side, and I'll make this brief as well, is that when we think about accountability within systems, now this is not something necessarily we can all do, but I think advocates could actually help to address this as well, is that when someone has a clinical trial, they all researchers, just so we all know, when you write a grant or you write a proposal for testing any kind of therapy, you have to complete this table, and we call it Table 4. And in this Table 4, you write down all of what you plan to do, including how many people of color, how many Black patients, how many white patients, how many women, how many men, all of that. That gets then submitted. And then yet there's never any follow-up in accountability. Once that grant gets funded, no one is holding anybody accountable to saying, oh, you're in your first year of that grant and you have not recruited any Black women yet. Oh, you're in your second year and you still haven't recruited any Black women yet. Oh, you're in your third year and you're almost done with the grant and you still haven't. And there's no repercussions, no anything. It just continues on. And so part of why the NIH report can say that our data is too white is because there's also no accountability for it not to be. And so if you don't have the accountability in place, how can you expect people to hold to it? If you've been getting funded for years to do these grants and to look for treatment and therapies, and yet there's no expectation other than you complete the table, but then that's about the extent of it, then yeah, it does create a little bit of a problem. And that, if you're not being held accountable to something, you're not going to necessarily follow through with it, especially if it wasn't something you were already doing in the first place. So I think that that's a key part. And I think patient advocacy groups could actually play a part in continuing to push that forward and making it become part of something we start looking at in terms of legislature, right? In terms of if we're going to start funding and we're using our tax dollars to fund programs, we need to be able to say, as citizens who are contributing to the tax base, and people who are diagnosed with diseases that need to be underrepresented saying, look, I'm advocating for me and the community that I represent. And I want to make sure that we put the appropriate accountability, that my tax dollars are being utilized in a way that ensures that I and people who look like me are actually represented in studies. That's what I want my tax dollars to be used for. So I think that that's another key piece. So I'll say those two things: patient advocacy connecting with policy, if you will, to start holding people accountable.
Well, it's really eye-opening to think that you could have an organization, whether it's the National Institutes of Health, some kind of grant maker, get the credit for saying, oh, we require this diversity questionnaire to be answered, but then that's it. What do you have to weigh in on, Dr. Farranju?
I was going to point out that, you need to also speak in terms of the currency that matters to investigators, and that is publication in high impact journals, and as Dr. Barrett said, getting grants. And also the potential of withholding that grant. So, not just the carrot, but the stick, if you don't meet those criteria. With regards to journals, there is increasingly requirements to at least report the diversity of a trial, which was not always the case. But I will tell you that, in July of 2020, when the first preliminary results of the mRNA vaccine was published in the New England Journal of Medicine, to great fanfare, and of course was the beginning of an important development with regards to ending the COVID-19 pandemic. Only 89% of the participants were white, 89%. And there was no discussion of how recruitment was conducted, even though the study was actually based in two diverse cities, right? Cambridge, Massachusetts, and Seattle, Washington. Nonetheless, they managed to only get 11% people of color. And that isn't that's not mentioned as a flaw or limitation. As I said, there is no mention of recruitment strategy. I thought about the ways in which people I knew were getting involved with these trials. And it's basically fellow faculty and our neighbors and our, in Chapel Hill, North Carolina, which is a very highly educated community. Those are people going online, with the internet they have and electricity they still have during a pandemic where people lost their jobs and lost their money, that they were doing that to get involved with trials. And so again, just recognizing the privileging of participation, that this is a trial that should have been doing everything it could to get people of color into the trial, people who were housing insecure, people living in circumstances that make them at risk for getting COVID because of the way they live, the jobs they perform, whether that's a chicken, hand handling factory, what have you. But none of that was done. They basically looked for healthy volunteers, which is not inappropriate in a phase 1 trial, but nonetheless, was that ameliorated over the course of the trial? I don't think it was. And it's really hard to convince people to believe and trust a system that never sought to look out for people like them.
That's very concerning that only 89% of the people in that study were white. And it makes you wonder, I guess my question is to Dr. Wingfield, do you see this changing? Do you see something that is effectively changing this, even in just the medical center where you are? And does there need to be a kind of policy change? Dr. Farranju mentioned the idea of not getting a grant, but if the grant maker is only asking you to fill out a table and there's no follow-up, how does that work? So what do you think in terms of carrots or sticks, or what you've already seen working and that should be expanded on?
Oh, we could talk about this for hours. And so let me tell you something. So I wish I could have jumped up and down when my colleagues were talking, giving their responses, because look, this is an area that I've been talking about for years. And I think those of us who have been in this space have been talking about it for years. Why is it that there are the same institutions who are getting these funds, or who are actually doing the clinical trials over and over and over again, when we know that they lack diversity? I was at a big institution in Boston, right up there, we're not too far from Cambridge, right? And look, we know how to write grants, right? Big academic centers know how to write grants. We know how to do this stuff, but there's no accountability. And so I think that this is where we saw the rubber meet the road. So while with the COVID vaccine, there was a big push. And I think this is where it was really important. We eventually got up to 30% minority accrual for that. So at least we can now say there's movement. So that's what I'm saying. COVID is really opening people's eyes. We've got to do things differently. We have to have inclusive participation. I help work with the NIH right now. There's SEAL teams, the Community Engaged Alliance Against COVID Health Disparities, where we are working on best practices for inclusion of populations who have been disenfranchised and excluded for a long time. So I'm hopeful, but frankly, this is about the sponsors. And let me tell you something, this is where pharma really needs to do their work. And this is where, to Dr. Barrett's point, this is where patient advocates can come in. This is where you can say, look, it's really important to my community. And oftentimes when you think about what the community is, let me tell you, yes, we're focused on diversity and inclusion, but please, any patient organization, metastatic breast cancer groups are very vocal because oftentimes a lot of the new therapeutics for breast cancer start, in patients who have metastatic disease. And so how can we kind of force the hand of sponsors? That means the pharmaceutical companies who are paying, or helping to support those clinical trials to really do their job. And I feel like this is one of the areas I'm so pleased by this appointment by the president to the National Cancer Advisory Board, because part of my role, along with my colleagues, is 17 others, it'll be 18 of us who are going to be sitting there and be like, so you researchers who know how to write grants, but you've been saying the same thing. Well, here's what we're hoping to do, but this is what we've done. We know those numbers are static. Now it's going to be time for the rubber to meet the road, because this is, again, the carrot versus the stick, right? And there are organizations such as Stand Up to Cancer that has raised millions and millions, hundreds of millions of dollars, and they're providing support to individuals at both of our institutions, right, to kind of conduct grants in a very different way, inclusive participation. And they do have the capacity. That's the difference between government and having a private foundation where they can say, you know what, you're not meeting accrual goals. We are going to withhold your funds. That's what really needs to happen. I think the FDA has been doing a wonderful job, but this is the challenge with kind of the way that our government works, is that the FDA can give conditional approvals, and they have done that. They've given conditional approvals for medicine, but then they go back to the sponsor and saying, you need to actually show that this is going to work the same in each population. And there've been several drugs over the past several years that have actually been pulled from the market because they're showing differences in terms of what's happening from a side effect profile or even from an efficacy standpoint in different populations. So again, diversity and inclusion is important in these clinical trials. Patient voice is vital. So please, for our advocates and our advocacy groups, speak up. And certainly there needs to be policy, but the policy is not just the national level. It's actually at the level of the institutions, at the pharmaceutical companies, to really make a difference in terms of this whole landscape around, inclusive participation.
Right. And it's not just holding these researchers accountable, it's who's doing the holding accountable and how are they doing it. It sounds like several of you have mentioned really what comes down to money. If you're not going to get the grant, or if you're not going to be able to market the drug, maybe that's what's going to have the impact. I want to talk about procedures in place to protect clinical trial participants. We may have people on this call who are saying, look, I've just enrolled, or I'm about to enroll, or I'm considering enrolling. What are some of the procedures in place that protect clinical trial participants, and what needs to happen to assure people that there are measures to protect their safety, to sort of ease their concerns? Dr. Fayanja, can you start there?
Sure. So for all clinical trials, there's a data safety and monitoring board. So there is a group usually composed of a combination of investigators with the trial, but mainly people who are outside the trial, who are observing the trial for aberrations in the safety and side effects of the trial over the course of time. And that there are routine checkpoints throughout the conduct of the trial, at which point there is an interim review of any unusual side effects, of any unexpected benefits, or if they're seeing that the expected efficacy that they had hoped to achieve based on the number of patients they accrued at that time seemed probable, or was woefully not happening, to the point where it might be justifiable to actually end the trial early, because they can tell that it simply isn't safe to continue having people on one of the arms if we basically get beyond equipoise. Equipoise being the idea that we truly don't know which arm is going to be better. So if we get to the point where it becomes clear really early that actually this intervention is not appropriate to really continue, then we can back off. And the Data Safety and Monitoring Board can help with that. The other thing that's important is that, clinical trials, a patient can stop anytime. You are not beholden to participation once you've originally started. And that freedom hopefully gives people the peace of mind to know that if it's for some reason for them, it turns out not to be a good choice, they can walk away with impunity. Another important thing to know about clinical trials and how people can, stay protected is that, you have clinical research coordinators who check in on you regularly, and increasingly clinical trials incorporate what are called patient-reported outcomes. So patient-reported outcomes are direct, information from patients about various things related to their health status. So quality of life, function, appearance, sense of self, fatigue. These are all things that are now being assessed as part of a clinical trial, not just did it recur or did it not recur? Did it grow or did it not grow? We recognize that wellness constitutes many things. And so that is being taken into account more than ever before. So I would say that, again, having a monitoring board, all clinical trials do, that look out for side effects and particularly look out whether there is disproportionately high number of those things that isn't happening. Again, interim analyses to assess whether or not the trial is conducting in a way that is expected or whether we're actually seeing too many unsafe side effects or events that make the trial unsafe to pursue. And then finally, patient-reported outcomes that patients can often communicate directly to the clinical trial team and their providers to make sure that if there are other aspects of health that are being compromised by the trial, they can speak up about that. And of course, you can walk away anytime.
Those are all important things to lay out. Dr. Wingfield, what do you want to add to this part of the conversation?
So again, I'm going to point to the COVID whole thing. I mean, folks may remember when Moderna actually had to pause their clinical trial, right? Because there were some concerns. Again, that shows you how effective those data safety monitoring boards are in terms of really looking. And I'm a clinical trialist. I've had clinical trials where literally every 4 patients, I had to call somebody in to kind of do a chart review and make sure everything was safe. And literally there were sometimes things that were completely not related that I had to report as an adverse event, and they get looked at. It's very, very serious. All right. And we saw that with COVID. But here's even a step beyond that. The institutional review boards, or IRB, okay, this is actually a mechanism by which researchers who actually have a concept and a protocol that gets reviewed by their peers, but also by community members. So again, we're talking to patients. You guys are on this call. If you're interested and say, I want to know what's happening at my institution that's close to my home around clinical trials, see if there's a way for you to become part of the institutional review board, because this is where your voice really matters. And, Dr. Barrett and I kind of worked together for a long time in terms of thinking about how do we train individuals, who may be patients or survivors or caregivers. Like, how do we make sure that you all have a voice at the table? And one way is for you to get a better understanding of how the clinical trials process works, and really kind of to learn how to have that interface, to have that bidirectional communication with research teams, and potentially to be a part of the institutional review board so that you can actually sit down at the table alongside the other people who are reviewing these protocols to say, you know what, I worry a little bit about this part of safety, or I worry about this, or tell me a little bit about what your accruals are going to be looking like. And that kind of stuff happens even before the protocol gets issued. And I certainly know from at least from when it's an investigator initiated trial, that stuff gets hammered in pretty succinctly. And I think we're trying to roll that out to some of the national cooperative group trials, meaning things like that actually look at those studies that are doing the comparison work, and looking at randomization. So I think that's one other safety that people need to know, that they can bring their voice to that table as well.
I think that hopefully patients on here who are considering a clinical trial or just join one and feel good about what they're hearing, that their safety is of primary importance. So Dr. Barrett, touch on that. We heard from Dr. Wingfield and Dr. Fayonju several ideas for how to approach this part of it, but talk about the importance of the messaging to patients about how central their own health is in this, in terms of researchers don't want them to do anything wrong to them. They want to make sure that they're able to sustain the medicine just as well. So explaining to a potential patient that not only is your safety a primary concern, it also matters for our research. Does that make sense?
Yeah, I think it really is important for researchers to be able to really ensure that patients understand their rights and their safety that's in place. And sometimes those conversations don't happen to the extent that they need to, even for people who do actually participate. The communication that happens between the two can be somewhat quite limited. In fact, people who have actually participated in trials actually say that sometimes it felt like at the beginning that it was more of a transaction than a conversation about participating. And so that in and of itself says a lot about the question you're asking, Athena, regarding communication. So I think that there's some critical opportunities there for sure. I think also when we think about, I often talk about it in two ways, but sometimes some could probably say it's they don't complement each other, but it is about being a volunteer. Without question, in the past and even currently, the term is often used as subject, right? So you're a subject in a study, and that in and of itself can be problematic. because subject almost feels like you have no say, that you're just there passively, right? Whereas as opposed to being a volunteer or even a partner in research, right? Because some of the studies may not benefit the person that's in a clinical trial, but most certainly can help to advance research for others who may be in that same situation in the future. And so I think that sometimes the communication just needs to be specific. It needs to be tailored. What we do a lot of now is that when we create we help our researchers actually to start thinking about developing their communication, their tools, the things that they do about their study, making sure it's culturally appropriate and culturally tailored, that we're not throwing in these research jargon that is doing nothing for that patient to be able to make an informed decision about being able to participate in a trial or not. And so I think that there's some critical pieces most certainly there that we can start to do better. I also know that engaging, and I have to just kind of piggyback on what Dr. Wingfield said about the IRB. You know, nationally, people who sit in that role as the community representative on a lot of IRBs nationally are actually retired providers. And so they are not necessarily people who are coming from the community that reflects the community. And I know that there's some work that's happening in BCU. There's some work that we're doing here at Duke, where we're creating clinical ambassadors that are really and truly starting to focus in on being able to serve in these roles and integrating our patients in our community into your health system as collaborators, as partners, informing the work, informing quality improvement care. In England, for example, Dr. Sandra kind of hit on this earlier, is that, you know, in England, in the past, historically, the research that looked at cancer and other chronic diseases oftentimes looked at access, right? Because in the US, we talk about access and we talk about quality. In England and in other countries where there's socialized medicine, the access part ends up not getting as much attention, and they actually focus a lot more on quality, right? The quality of the care. So you may be able to get in, but that doesn't mean now everything's good. It just means that you're in. But then the quality could be completely a mess and contributing again to those disparities. So really integrating our community and our patients, both obviously as research participants, but also as stakeholders that can help to inform the research. And that actually makes the research better. And so the more we can engage our patient advocates to become patient research advocates as well, I think that that's important. One is about their care critically. We want people to do well first and foremost. But secondly, part of that and improving that health is engaging and integrating our community and our patients in that system. And so I think that that's something that we need to do better, and tailoring the materials to fit. We actually subcontract with two of our Latino community-based organizations, and they actually work with us on developing our materials in Spanish, right? And making sure that it's relevant to the community, as opposed to us kind of making it in our little walls behind the university saying, here, now, I know you can relate to it.
Right. Wonderful. Well, listen, we have a little less than 10 minutes, and I want to get to some of the audience questions. And I'm wondering if maybe in this sort of part of the round, if whoever wants to kind of jump in to answer, we can maybe get through 3 of them rather than do the whole loop for everyone. And one of the first one we got, I hope she's still here watching, is, sorry, it's this one. What do you suggest if the clinical trial you want to join has no more spots where you live and you can't travel? And maybe whoever answers this can also provide general advice for people for how to find and get involved in a clinical trial.
So I'm happy to kind of take this. I think so. If you're interested in a clinical trial, I think one of the things to do, number one, there is a government website, but it's a government website. So it's called clinicaltrials.gov, but it's not the easiest thing to kind of to go through, but you can actually sort, you can find clinical trials that are close to you. All right. The other thing is to go onto your website of the institution where you are, right? And to go and to look to see what's there. And for folks who may not have access to the internet, just asking your provider. And if they don't know, say, well, could you please look into this and get back to me? Okay, that's your right. And I heard Dr. Barrett, I think, say in her talk that if you have a provider who's hesitant, then you might need another provider. This is your body, and clinical trials shouldn't be something extra or other. They should be part of the standard operating procedures for any patient who has a cancer diagnosis. Okay, so let me just say that. And I think it is a challenge. Know that these clinical trials, oftentimes there are limitations in terms of how many the number of people that they actually would like to accrue, but that doesn't mean you can't connect with the actual principal investigator of the trial and see, because sometimes they may be able to extend or expand the cohort, meaning the number of people that they're actually bringing into the trial. So that name is actually on the clinicaltrials.gov website. And oftentimes, if there is an institutional website, they'll have the name of the principal investigator and how to contact them. All right, their email. So you can it's a little bit of an extra step. And if you don't feel comfortable doing that, you can ask your primary care provider to assist you, but know that your primary care providers sometimes are a little bit overwhelmed, but that's a conversation that you can have with one of your providers to help. We do know that it's hard for people to travel, but for those who can, this is where organizations like the Lazarus Cancer Foundation can help support, right? They will actually help pay and provide, resourcing for individuals to travel across the country for participation in clinical trials. Now, the challenge with the way that their program is currently run is that oftentimes you have to pay upfront and it's a reimbursement program, but at least there's that resource and you can contact them. That's the other way to look for clinical trials, is to go to patient advocacy organizations, and they can sometimes help to guide you into where to actually find a clinical trial that's closer to you. And just know that, look, if the clinical trial is not available to you, sometimes there's opportunity to actually ask the sponsor for, compassionate use, but that's pretty unusual. I think really we would like to gather information in the form of a research study. That's the best way to do that. And then there are oftentimes other opportunities that, while that particular clinical trial might not be available to you, they may have other treatments that can help bridge you until there's something else that's available for you.
Wonderful. I have one more question before we get to the final question for everyone to answer, and that is, this is something that Dr. Barrett touched on early on. Perhaps you'll want to expand on this, Dr. Barrett, or maybe you can weigh in, Dr. Fayonju, but this idea of a sugar pill, this idea, if someone may be considering enrolling in a clinical trial, but they're worried they're not going to get good treatment, I think this is important to end on a note where people understand what's really going on here. There's a common misconception that some patients would receive essentially a placebo, a pill with just sugar in it, which would be inactive and wouldn't, of course, treat their disease. Talk about how that's not what's going on in these clinical trials. Dr. Barrett or Dr. Fayonju.
I'll leave that to Dr. Fayonju.
Sure. Clinical trials, again, are typically trying to compare a new intervention or innovation to standard of care. That is what already exists, that is known to be effective for a treatment, and we're hoping to find something better. That is many types of clinical trials. And in those trials, again, you would not be getting nothing, because that is not standard of care. You'd always be getting something, either what is already known to be an effective treatment or something that's being investigated as hoped to be a better treatment, or at least equivalent, but potentially with other benefits, such as improved means of taking it. It's not IV, or it doesn't require as long a treatment session or something like that. That being said, there are many different kinds of trials, and it's important for people to realize that not all trials that could benefit them are what we call therapeutic. There are some trials that are interventions, but that are not specifically about treating the cancer. So for instance, trials that relate to weight loss or relate to mental health, those things can influence the course of cancer, but it's really about, again, thinking out the whole person and the wellness. And so the treatment that might be or the intervention being proposed is not specifically about that. So don't think just because you may not be getting, a particular drug per se, or something else, that means you're getting a sugar pill. The goal is never to give you nothing. The goal is always to give you something, ideally something we already know works well, or something that we hope can work better.
Excellent. It's so important to make sure people understand that. So the last question, I think it's perfectly geared for a lightning round, and we can just go, and the order of my boxes are Dr. Barrett, Dr. Wingfield, Dr. Fayonju. If each of you can answer this question, which is, can each of you share the single most important thing you want people to take away about diversity in clinical trials with this session? Dr. Barrett?
Yeah, diversity in clinical trials is an equity issue. It's critical that we also think about it in the context of patient advocacy and self-advocacy. And without having the diversity we need, we are actually compromising our ability to do rigorous science that can actually close the gap in the disparities I described earlier.
Excellent. Dr. Wingfield?
I'll echo that, but I also want to talk a little bit from the patient perspective in terms of financial toxicity. We know that cancer care is actually the #1 cause of medical bankruptcy in the United States. And so clinical trials can sometimes be there may be a little bit more visits, or it might require some more attention that you might need to come in. So it might cost more from a patient perspective, but here's the thing, ask for help, okay? I want to empower you. If you're interested in enrolling in a clinical trial, please ask for help. There is support available for you to actually enroll. And I think this is one of the things that we need to be thoughtful about. They might not be able to support everything, but I think it's important for you to speak up. And particularly when just standard of care, cancer care can be expensive. This may be an opportunity for you to not only provide support for, research, but also, something that can benefit you, potentially benefit your communities later on, but really an opportunity for you to speak up and say, this is what I need. And don't be afraid to do that. And so again, our diversity, it's really important to have diversity in clinical trials so that we know that the medicine is going to work well for everybody. But we also understand that there can be burden, and we want to support you in that journey.
Thank you. It's so important to talk about the cost of this access to care. Dr. Fayanju?
I'm going to go for the long game. Dr. Barrett and Dr. Wingfield have both eloquently described what you, the individual, can do to access clinical trials and get clinical trials available to people you love. I'm going to ask everyone to think about the future and about the fact that in the end, the stakeholders who need to be at the table need to be a diverse group of individuals who are going to speak for all kinds of people in terms of prioritizing research questions and ultimately, hopefully, being the people who hold the power to fund the studies and do the research. So I want you all to encourage your sons, your daughters, your cousins, your nephews, your nieces, your grandkids, yourself to be a scientist, to think about being a scientist, to know it's something that is open to all of us and that will ultimately lead to the change of the players in this game of science. When we have those people on all of us at the table, it's going to change the game. And it's going to mean that it's no longer something you have to think of as a side project. Oh, we do disparities work. It's going to be that it's everyone. We're there. We're narrating the story, and we're making that story belong to all of us. So that's what I want everyone to take away from home: is you too can be a scientist, and you too can make science. So do it and encourage someone you love to do so too.
What a great way to end. Thank you so much. Thank you to all of you. And I'll hand it back over to the organizers, Dr. Weiss.
So I want to thank you, each and every one of you. Thank you, Athena, and thank you so much, Dr. Barrett, Dr. Fayanju, Dr. Winfield, for that informative and fascinating discussion and for the work you do every single day. Now it's my pleasure to welcome Sandra Omaro. She's head of clinical trial diversity at Pfizer, and Pfizer is a generous sponsor of this event. Thank you so much for being here, Sandy. You heard the discussion. Please tell us, how can the work Pfizer, what kind of work is Pfizer doing to improve access to clinical trials?
Hi, powerful session. I think here at Pfizer, we're doing a really big focus on equity. And one of our pillars, so 4 of our major pillars for our company is equity. And I think a lot of the last conversation was really focused on equity and access to care. And equity is something that all of us here at Pfizer, regardless of your role, regardless of what you're doing, whether it's clinical research or operations, we all carry and are accountable for equity and inclusion. My role at Pfizer is focused on clinical trial diversity. And what we're doing here at Pfizer really predates COVID, right? So I think COVID-19, as stated in throughout this conversation tonight, really put a spotlight on the disproportionate impact that a disease like COVID could have on communities of color. I'm proud to say that I was actually in my role really focusing on equity and inclusion before COVID. However, COVID really put the spotlight on it, and it really allowed us to look at this a lot differently and change the way that we operate. Over the course of the last year and a half, we've grown an organization that's solely focused on equity and inclusion in clinical trials, how we enable our clinical teams to talk about the clinical development plan, how we design our protocols, and really taking a listening approach with advocacy organizations so that as we design our protocols, we understand the barriers to entry that exist for these patient populations and how we can adjust those and address those in the way that we design protocols, and then how we execute those protocols. We are also really focused on where we place our investigator sites. So where do we run clinical research? And so we're taking a really deep look into where we have clinical research sites now and where we have opportunities to grow research sites in communities of color, partnering with healthcare providers that serve the community so that they can be a voice and an advocate for clinical research, and that we can bring clinical research into communities that have been underserved in the past. So site selection and where we place that research is a focus right now for us, as well as growing research naive sites, not just going to the same institutions, large academic institutions that sponsors typically go to, but how do we grow that pipeline? And how do we grow a diverse clinical workforce, and not just investigators or the primary doctor, but also the nurses, the site coordinators, the data monitors, IRBs, making sure that throughout that whole scientific clinical workforce, we're helping support and enable growth in that pipeline. So that's also a focus for us.
That's great. I mean, that's a great vision for the next, for this year, 5 years, 10 years. And clearly the research questions that we're pursuing need to be relevant, compelling to those people to all people for participation, especially those who have been underrepresented, who have needs that haven't been addressed. That if our research questions are much more relevant and urgent and compelling to those populations by listening and taking them seriously and having them be represented themselves and those people that they serve around the table when these conversations are taking place, will make a huge difference moving forward. So thank you so much, Sandy, and to everyone who participated in tonight's event. Thank you each of the people who've come on to listen, to learn, and to hopefully share what you've learned with others. Please give us feedback. That's how we get better. And this concludes tonight's program. Everyone will receive a recording next week, a link to that. And you can read our new special report at breastcancer.org/clinical trial diversity. Thank you for joining us and for being such an important part of the breastcancer.org community. We look forward to seeing you again soon. Take care.